Am I offending? Sorry about that. Do you know the prevalence of smoking tobacco in India is three times less than the prevalence of untreated dental caries in Indian population. Tobacco use is not the major or most common problem the public is facing. It's just 28.6 percentage. But untreated dental caries is around 78 percentage. Myself, Dr. Joby Peter, thanks the organizers of Indian Association of Public Health Dentistry for giving me this opportunity. And I will be talking about preventive dentistry. I am hailing from Anur Dental College, my parent institution where I work as a professor head of the department. I welcome you all to my college for any association you would like to have. This is a very important study which is recently published in 2018 by Chandrasekhar Janakiram et al. And they compared four groups, BMFT index in four groups, pediatric, mixed dentition, permanent dentition, and geriatric dentition. And they found out that BMFT of elderly are increasing. That is an alarming situation there. You take or talk about dental caries in any part of the globe, it is present there. Even in Antarctica, you have prevalence of dental caries there. So around 2.4 billion people, 240 crore people, that is almost double, almost equal to the double of Indian population there, a little less than that. And out of this, most worrying is 0.62 billion, that is around 62 crore under 5 years of age, primary dentition. Children are affected by dental caries. And this is from the latest study 2020 published, Burden of Dental Caries in India, Current Scenario and Future Strategies. Lancet in 2017 published the data where said that South Asians are under high risk of dental caries, and among them, Indian have a higher incidence of dental caries, and more females are suffered from this problem as compared to males there. So, guys, we have a problem. You like it or not, we have a problem there, and we need to tackle it down. How? Preventive dentistry is the solution for that. You know, public health dentistry is doing an amazing job, and this conference is a part of that. More than 3,000 plus registrations. Salute to them. They are organizing it. And so many researches are happening. So many things are happening in public health, dental education, awareness, cancer awareness. So many things are happening. But there is one somewhere, there is some lacunae there. There is some aspect which are not reaching the people in the right way. Even pediatric dentist, I'm a pediatric dentist, I also have some part in that, that we are not reaching the community in the right way. We need to think retrospective. What could be the reason? And my aim here is both of us should join hand in hand and should exchange ideas, research methodologies, and apply things in a more clinical and practical way. That is my aim, person in front of you, about application of preventive dentistry clinically in a professional way so that we can aware, make the parents and the patients aware about this more easily. Let me tell you, you might have heard about a famous saying that the dog's tail, it cannot be straightened no matter how many millions of years you put into a tube there. So it's not easy to preach, to educate an old patient, but it is easier, moldable, yieldable when the patient is in his younger age. So that's how this pediatric dentistry, preventive dentistry from young age, it will be more beneficial, more appropriate in preventing the dental caries there. I would just want to start with a case experience which has happened to me. A 1.5-year-old patient mother sent me a WhatsApp in November 2019. They were in Gulf. So we had a telephonic conversation. So they sent me a picture of this and said my sons and daughters' teeth are whitish in color, some kind of whitish discoloration. I can say, should we do something? I immediately told them, madam, this is not right. You need to go and see a pediatric dentist or a dentist, but they didn't have time because Corona, all those things came, and they were all planning to pack to India by May, June. But since the India had a lockdown, everything got cancelled. In March 2020, she sent me a picture, sir, it is getting worse, sir. I could see that this is the condition. And I said, they can't move. And by October 2020, they gave me a picture of this. So within a span of an year or so, you can see the devastation that has happened. So quickly it has happened. And I was helpless, they were helpless. This is happened there. And what is this condition? We all know it is early childhood caries. No matter what our home hygiene measures we told, asked her to do, professional care was required for this point of time, and she was unable to get the professional care. Early childhood caries is a condition which required immediate attention there. The whitish band around the neck of the primary incisors, which will lead into cavitation and total destruction there. And there it doesn't ends. It doesn't ends there. This is another patient who's 18-year-old female with 14 multi-surface caries lesion there. So it doesn't ends in the primary dentition. That is one myth we need to break. The parents, the society, the community, we need to break. It doesn't stop with the milk teeth. Always they have a myth that it's a primary teeth is shut off, so we can just forget it. No, it gets transferred into the permanent dentition also. So what we have to do for this? Usually when this happens, the saddest part is the parents. The, 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 the relief of the parents is we have to go to a pediatrician because that can be a discouragement. They never think about a dentist or a pediatric dentist. And pediatrician gives them medications because they know that enamel is full of calcium. So calcium is going, calcium is deficient. Let us give calcium syrup. And osteocalcium is one thing they give very common. And it worsens the situation because it contains sugar syrup, and sugar multiple exposure is the reason, ECC is reason there. It worsens the scenario there. And it ends up in this with pain and swelling. Now they say, no, why can't you go and show a dentist or a pediatric dentist? We are helpless at this point. This is a common situation that is happening there. And let me tell you, we cannot blame the parents because the education, the awareness among the parents, society, public, community is less. We need to work on to that. We both have a responsibility in that. So the solution for this is preventive dentistry, nothing else. That is the solution for this. So preventive dentistry, first and the foremost thing, when it comes to clinical application of preventive dentistry, forget about this dental health education, dental camps, and surveys. Oh, we got the data done, but let us come to the reason. Let us come to the main problem is awareness among the parents and the patients is still not much with what dental caries I'm talking about. They know that if you have smoke cancer, use tobacco cancer, awareness is very good among them because that much work we have done. PhD has done so much good work that they know that tobacco use is cancer. But dental caries in primary dentition, milk teeth, shed of teeth that also require care so that it doesn't transfer into the permanent, they don't have that awareness, which we need to do that. Then diet modification, home hygiene, and professional care. And professional care, I do it in 3 steps, sorry, 4 steps, which I'm going to stress here in my next 20 to 25 minutes of my presentation there. So what is the first step that you have to do? Make the parents aware because pediatric patient, we have to make the parents aware. First thing is not the patient, parents aware. They are the one, they are the key holders. Yes. So you should educate the parents that whenever the teeth erupts, that is 6 months or 4 months, 5 months, you should start the care for the teeth. And what is that? Lift the lip procedure. Every breastfeeding or bottle feeding mother, when the first teeth just started erupting, parents should lift the lip of the child, upper lip usually, and see that in a discoloration, whitish band like this, which I've shown is present or not. This is recommended by ADA, American Dental Association. Lift the lip procedure for every parent's dental who's having a breastfeeding child under 6 months of age. If anything is there, they have to report to the dentist there. That whitish band is called the first sign of early childhood caries. Then the step one continuing, make the patient aware. That means now the child or the patient is grown up, like 12, 13, maybe age or adolescent it has become or geriatric it has become. Now we have to educate the patient that this is not going to stop with that particular filling tooth. There is some problem with this there, which we need to address it there. So make them understand that your hygiene itself is very poor. Then how can you expect my fillings to be stay there? How can you expect the saying that dental caries doesn't occur, that is permanent filling, it's not going to shed out or it's not going to fall off? How can you tell them? Every 2 years you can see patient again come back with the new caries there. So we have to make the patient aware that this is not going to stop with this one particular teeth because there is an inevitable problem that is inside your mouth. Show them that. Let us focus on the mouth. So show them what is happening inside the mouth. Use of plaque disclosing solutions, which will say, oh, this is my mouth. Oh my God, this bad it is. Yes, this is your mouth only. I am brushing every day. Yes, you are brushing every day, but twice I'm brushing. Yes, but you can see the amount of dirt which is adhere onto the teeth because many reasons. Now you expect me to do a filling into this mouth and say that it's going to stay permanently? No chance. So use of plaque disclosing solution is one big thing that you can do in your clinical practice to make the patients aware about it. And nowadays, their latest plaque disclosing solution, which can detect pre-plaques or biofilm. Plaque is not used biofilm, 3 types of biofilms. That is, pink one will be a mature one. So new plaque is a pink one. Mature one is a purple one. And acid producing, the most dangerous one, which was demineralization and cavitation, is the light blue one. So you can see Rangoli on teeth, literally. So this patient is in danger of getting dental caries or high risk of getting dental caries. First and foremost thing is a prevention rather than drill and fill there. So GC has come out with GC tri-plaque ID. It's very good. You can buy that. It costs around 3,000 rupees per tube, and you have to charge for your that also. Step two is home care instructions and agents that can have home care instruction agents which can prevent dental caries or reduce the amount of dental caries there. Now, supervised tooth brushing is the important thing that can drastically reduce around 35% of dental caries. And if you add fluoridated toothpaste, it's around 10% more reduction in dental caries can be done. So supervised toothbrushing. Proper toothbrushing is very important. Followed by fluoridated toothpaste, not the normal one. But our dentist, we give fluoridated toothpaste. We go for advertisement. Sensodyne, oh my God, which I have to give that. That's a good advertisement. No way. For Colgate, this, that, we use. That is not the way to select a toothpaste. To select a toothpaste, you have some certain things should be there, especially fluoridated toothpaste. Let's see one by one. Any child who is under 7 years of age but low risk of caries, the recommendation says that you can start using a 60 ppm less fluoride content toothpaste if there is no water fluoridation in that community is there. They are not coming from a fluoridated water community or from a high fluoridated water content present area like Alapi in Kerala, like in Nalgonda, where are all people have got fluoride present in the water. Natural high amount is no need. Otherwise, if the patient have low risk of caries also, it is advised to give less than 600 ppm of fluoride, below 6. And I will tell about how much quantity you have to give. And if the child is having ECC, which I have shown you, early child multiple caries lesion is present, then child who's below 7 years of age, the recommended amount of fluoride present should be around 1000 to 1450 ppm. Below 7 years with high risk. But the quantity used is mere or pea size, very little. 2 times a day, you can ask the patient to use that. Now, any child above 7 years of age, high risk, 450 ppm of fluoride should be there. There is no size. Normal amount should be taken in the brush should be given. I will show you that. So this is very important thing in decision making in taking a toothpaste there. So brushing advice, which I have told you, the amount to be dispensed in the brush, this picture will give you, that is smear layer, which I have told you. Child 0 or 6 to 3 years of age, smear layer, fluoridated toothpaste. Children 3 to 7 year pea or grain size. You can see the quantity. And above 7, half the brush. Half the brush. This is the protocol. And once the brush is dispensed, tell the parents to press the paste into the bristles before starting brushing. But our advertisements, our companies are smart enough to sell maximum product wastage or consumption happens because of this. This is bad. We should actually file a complaint that this should not misleading advertisements are done by the companies. This is actually wrong. No way, even adult does not require this much quantity of paste to brush the mouth. Step 3, home hygiene, home agents are over, is professional care. What professional care you should be giving for them. It comes under agents that inhibits or prevent rapid spread of lesion. 3 agents methodology is there. One is the agents that inhibits or prevents spread of the lesion. Second one, agents that remineralize it. Whatever demineralization has occurred, this agent will remineralize it. And methods that keep the teeth self-cleansing. Imagine teeth are all well secured, covered nicely, smooth, no rough surface are there, pits and fissures are all sealed. It's easy to cleanse them. Self-cleansing it is. So these 3 ways by professional care you can prevent dental caries. These are the procedures you do in your clinic there. So the best methodology to do or agents that inhibit the spread of lesions fluoride till time this you cannot avoid this or not have this thing in your clinic is a criminal offense. Let me tell you, because this works for all age group and fluorides are available in a gel form, varnish form, and for the most common things I have brought in there. These 3 things you should have in your clinical practice there. And among the gel, APF gel is one that is most commonly used or easily accessible. Good result if you judiciously use this is there. So it is acidylated phosphate fluoride APF gel, and it is contain 12,300 ppm of fluoride or 1.23% of APF is one that we use. It's available as a gel form also. And so many companies are there. One company which I use for my 6 to 7 years, I find it's very good, is a gel company. The advantage is 60-second application. So younger patients easily you can use it. In adults, if you keep it for 3 to 4 minutes, it's best. But 60 seconds is sufficient. Protection can be given if you use judiciously this one. So gel, the Pascal is the company. There are other companies in other parts of the world or that are good, but in India, one company that is available good is gel Pascal. Once you buy it, once you open it, please keep it in the refrigerator to make the solution with high concentration. So the temperature should be less than 25 degree. Room temperature would be the ideal temperature to keep safe in that material there. Now, how will you apply? You have to use spray technique, and you can get foam trays, soft polystyrene foam trays are available. These are the different size, small, medium, and large trays are available. So you can select any of these trays according to the patient's fit. You can apply, and you can load the tray and keep it inside the patient. Usually, we load the lower and then go for the upper in younger patients. In adults, you can combine upper and lower can be togetherly loaded and kept inside the mouth for 1 minute, 60 seconds or more time. If the patient is comfortable, you can use that. And you have to load. Now, how to load the tray? The lower tray is loaded, then the suction, high vacuum suction is kept, and then you keep the upper tray and keep it inside the mouth and ask the patient to bite 2 to 3 times. Ask the patient to bite so that it spreads into interproximal area because of the thixotropic property. When apply pressure, it becomes more liquid and spreads into the interproximal area. So how much amount should I take in a tray? The rule, irrespective of small, large, and medium, 1/3 of the tray. That's adult or whatever age group, 1/3 of the tray, not more than that should be. So that means 2 gram, maximum 2 gram or older, more for older people. So 1/3 of the tray would be the ideal one. Should be less for younger children there. So patient should bite hard, chew it hard after keeping 2 to 3 times, chew it so it spreads and then stabilize it and keep it for 1 minute or more time as the patient comfortable is there or not. After the application, what are the instructions that you should give? Do not ask the patient, do not drink or eat for 45 minutes. Ask the patient not to, ask to spit maximum. The patient should not eat or drink for 45 minutes. Tell them to spit maximum so that it doesn't ingest it there inside. Application schedule for gel and foam. The foam is like a what do you call? It's like an ice cream. So you can use gel and foam with the same protocol which I told you, but the schedule of application is depending upon the risk of the case. Is it medium, no risk, medium risk, or high risk? Low, medium, high risk. So moderate risk, 2 times application would be good. Application of gel or foam would be good. But high risk once in 3 months, that means 4 times a year application would be best for a high risk patient. That is a application schedule for gel or a form of APF. There. Now, fluoride varnish. That's another methodology that can be used is use of fluoride varnish. Now, when do you select fluoride varnish? Ideally, I select fluoride varnish because of patient complaints is very less for this gel gagging, and they don't like the taste, and they don't like this jelly thing. Some patient children doesn't like it, so I go for that. Second thing is risk, high risk. I always go for varnish. Moderate risk sometimes. Otherwise, I always use varnish for high risk patient mandatorily there. That proves to be better. Your control. What are the varnish available in India? Durafet by Colgate. You have 3M ESP Clean Pro 5% sodium fluoride, then bifluoride 12 and Fluor Protector by Ivoclar. All these companies are good, which are available in India. I don't say that one company. I'm not here to promote any company, but these are very good in protecting the dental caries there. So how will you apply fluoride varnish there? It's very simple. It's called paint on technique. Just paint it onto the tooth and dry it. Done within 3 to 4 seconds, it get dried. So just brush onto the teeth, proximal area, in the proximal area. Brush would go there, occlusal, all the surface. You just put it and just air dry it. Immediately it sets there. That's the advantage of varnish. Very quickly, 2 minutes, you can finish application of varnish if you judiciously use it. Instruction for the patients. Some instructions: do not eat or drink for 45 minutes to 1 hour. That is very important after varnish application. Spit out maximum. Tell the patient spit out maximum. Soft food for the day. That's very important. That varnish should stay there for maximum. It forms a layer, right? So it should stay there for maximum. Do not brush for the day. Tell them not brush today. Tomorrow morning you can start. A brownish discoloration will be there because usually the varnish will have a brownish or a creamy. Now the MI varnish, which is come latest one, has got a creamy color. So that color and scale like things will come out. That's okay, normal. Within a day or two, it will go. Do not worry about it. You have to instruct the patients there. What are the clinical uses of varnish? When are we? I told you I usually go for moderate or high risk category patients are there. That's the one. So rampant caries, like which I've told you, ECC or a rampant caries, patients who are under frequent medications, who are undertaking drugs that inhibit saliva, serostomia can cause, dry mouth, differently able, medically compromised, patient with the Down syndrome, some diseases they have, patients who are undergoing radiotherapy or planning to go for radiotherapy, which all causes salivary reduction there. So they are high under a high risk of dental caries there. So those people, that's what a high risk category we use there. You can see a patient with an active caries issue, very bad oral hygiene. These conditions definitely I should apply fluoride to prevent the dental caries or make the enamel stronger there. Orthodontics, especially during the time of orthodontic treatment, it is important or mandatory to apply minimum 2 times a year fluoride varnish. That can prevent white spot lesion after the removal of your brackets. Otherwise, the tooth will get white spot, brittle, and MOD caries will become very common there. Geriatric patients to prevent root caries and sensitivity when there is a initial gingival recession is there, slight abrasion is there, or a toothbrush abrasion or anything is there which causes slight amount of sensitivity. You don't want to progress further because cementum is very weak. It can again abrade. So fluoride varnish application twice in a year is amazing. It can stop sensitivity at the same time, prevent caries spread or the root caries spread for a geriatric patient or a disabled, differently able patient who cannot, bedridden patients. It will be helpful for this fluoride application then. How many times a year we should apply fluoride varnish? Again, low to moderate, I recommend you 2 times in a biannual is more than sufficient. But caries risk comes twice every 6 months. That makes 3 to 4 times a year will be required for fluoride varnish application. So this is the schedule of fluoride varnish application for moderate to high risk of category. So patient is low to moderate, you can go for gel or a foam. Patient is moderate and severe, the poor oral hygiene due to some other medical conditions are there, always go for fluoride varnish. Any company which you go, you can go. And application procedure, 3 to 4 times would be better. And the third category which I've told was pit and fissure sealants, an amazing things which can change your revenue of your clinic. And an amazing tool that can be done is making the susceptible pits and fissures as a self-cleansing area. We hardly promote this problem. In Western countries, every children whose first permanent molar comes, they do pit and fissure sealants. And that is the reason of reduction of dental caries in Western countries, in many of the countries there. It has been proven that the prevalence of dental caries can be reduced with respect to 6-year molar if you use judiciously pit and fissure sealants there. So this is a case where the parents have come, everything is perfect, but we can see susceptible grooves and fissures are there on the first molar. So advice pit and fissure sealants are the one. And the company, again, I am not here to promote one particular company, but 3MSP is a good company. Cling Pro from 3MSP is good. And the company Helio Seal F, which contains fluoride, F stands for fluoride. Ivoclar, Vivadent has got another company that can be used as a pit and fissure sealants in your clinics. So just want to show you a case discussion. This is a 6-year molar which is recently erupted, which is have got a susceptible grooves and pits and fissures are there. So how will you apply pit and fissure sealant for this? First and foremost is to clean the tooth surface. Look at this, how we are cleaning the tooth surface with a rotary brush. We are cleaning the tooth surface. No paste, pumice, nothing. Just clean the occlusal surface of the tooth. That is the first thing that we are doing it. Then just check with a probe, just check any cavitation or any debris is remaining there or not. Cotton roll isolation is sufficient for pit and fissure sealant application there. Then once you have isolated, nothing is there, then you go for etchant application. So next third step is etchant. Put the etchant onto the surface of the teeth, then spread the etchant with the help of an applicator tip. Many people does not do that. Just spread the etchant, all the two susceptible glue areas surrounding. Maximum retention you want, maximum spread it, the susceptible area spread it, and wait for 15 to 20 seconds. Waiting is done. Then rinse it thoroughly. Rinse it thoroughly for another 10 to 15 seconds. Properly rinse it thoroughly so that tooth appears chalky white. You can see the chalky whiteness appearance of that. And then dispense this sealant onto the etched enamel surface. You dispense it, and then immediately do not cure it. What I am doing here is I'm spreading the sealant. With another applicator tip, I'm spreading the sealant all around the tooth. So all the etched surface will absorb and get micro tags there. Very important step for retention of the sealant. You will get a sealant like this. And check for your high points. So after curing, you check for high points are there. No high point should be there. To run the scope, no air bubble, no high point should be there for this. If there is a high point, you have to redo it. That is a rule that you are not supposed to reduce it high point. No way. That will make the sealant weak. You have to completely scrap it out, clean it out with the ultrasonic scaler and redo it. So the steps is clean the tooth surface properly, dry it, observe for any catch or anything, and apply the etchant, spread the etchant maximum area, clean it, rinse it, then apply the sealant and spread it also, and light cure it and check for high points. That's the way of sealant application there. This is a tooth where the patient upper arch sealant application before our self-cleansing area I made it. This is, if I do not do it, you can see that molar 2 years time it will become like this with caries, with deep dental caries it will become. Lower tooth, I have done sealant like this. So it is now become a self-cleansing. Now you have given opportunity for the patients, the parents to improve oral hygiene and make the tooth self-cleansing. Now it's their responsibility. So you have to inform them, I have done my part of making it clean, neat, protected. Now it's your part to preserve it. That has to be done. Now, amazingly, you can see after 2 to 2.5 years, the sealants are still intact. I'm so happy that 8 sealants are still intact in these patients. When I applied, it was like this. You can see the sealants after 2 to 3 years, it's still intact, and all the teeth are caries free. That's the beauty of judicious application of pit and fissure sealants, which in our clinical practice there. The last part of it is the remineralization technology, which is recently that has come, which has plays another important role. As you all know, the enamel, when it's attacked by the acid, it goes demineralization. The calcium and phosphate goes out and microporosity happens there. That is because of the acid produced by the bacteria and the plaque causes that. So underneath every plaque, this is happening. Demineralization is happening there. So that is the loss of calcium and phosphate from the enamel. And when it increases maximum, porosity occurs. When the porosity increases maximum, what happens? Cavitation occurs. Dental cavity decay. So sign and symptom is cavitation of dental caries. The process continues there. How we can reverse it? By applying remineralization agents are there. When you apply this remineralization agent, they get filled in the saliva. So whenever there is a demineralization process taken place, this plaque absorbs this calcium and phosphates. So plaque is filled with calcium and phosphate. So if any calcium and phosphate goes out of the enamel, it will be replaced by the pH or by the salivary calcium and phosphate, which is enriched because we apply this remineralization. So whatever area of the oral cavity tooth there are demineralization, When we apply this remineralization solution, the calcium and phosphate specifically go and bind into these areas. That's how remineralization occurs there, of enamel occurs there. So how can we do that? What are the methods available there to do remineralization technology? Now, GZ has come out MI paste, which contain calcium casein phosphate, ACP, CCP, we call it, which have, when you apply onto the saliva, so much calcium and phosphate will be released onto the saliva. Saliva becomes super saturated with the calcium and phosphate. The pH will come down to neutral pH there. What happens? Reverse of demineralization, of course. All will go and bind onto the enamel there and stop demineralization, make the enamel stronger from another acid attack. So it keeps on continuing there. And recaldent by GC also contains CPP, ACP. All these things can be used as a remineralization to prevent. In adult patients, little more older patients who are undergoing various orthodontic therapy, it's not possible. You can ask them to use these chewing gums, which contain the same agents. So this can be also asked them to use so that it can reduce the amount of caries developing there. Instruction for using remineralization paste are used once daily or twice daily after brushing. Once daily or twice daily after brushing, depending on the caries risk. High caries risk, are use 2 times. Moderate, only 1 time a day, but only after brushing. Clean finger. Make the finger clean with water or soap and dispense it sufficient quantity and ask them to apply all the occlusal surface, buccal everywhere, just like after this. This is doesn't form lather. Okay, this is not a paste, it's a cream. So it doesn't form. So ask them to apply. If you want, you ask them to use a brush can be used. 1 gram will be sufficient to apply for entire upper and lower arch. All the surface of the teeth has to be coated there. Leave the teeth undisturbed for 1 to 2 minutes. That means after application, the patient has to hold it. You can switch the saliva. That is very good. Older patient, younger patients, not possible. Just apply and leave it. At least some protection will be there. So that will be good. And expectorate thoroughly. Ask them to spit. Do not wash after application of the GC mask. Do not rinse. The last thing before bed is be there. Okay. Minimum 30 minutes they should not do. But night time, my suggestion is last thing after that, no water, nothing, go to bed, rinse it, spit it out. Not rinse, spit it out. Maximum spit, spit, spit. That give maximum protection for the patient. So where are we using it? White spot lesion. Where you see white spot lesion is there, and fluoride you apply. But there are white spot lesion that you need daily protection. We have to give follow up with GC mouse remineralization. Daily protection you need. You can't apply fluoride daily, so you need to give this there as a desensitizing agent. You can be given patient with a mild to moderate sensitivity. You apply fluoride or desensitizing paste or whatever you apply, but apply this also daily. They can see the sensitivity slowly reducing there. After bleaching, patient might get sensitivity. Ask them to apply this one in along with the bleaching tray. Ask them to apply this also and keep it inside so sensitivity can be reduced. Enamel stripping for orthodontics, if you're doing, you can use this. Patient undergoing fixed orthodontic therapy, mandatorily we ask them to buy this from Amazon. Over the counter it is. You buy it and keep it, and after brushing you apply this every day to prevent white spot lesions there. Dry mouth with xerostomia will be the caution. With only this is patient is allergic to milk protein. Milk protein allergy, do not ask them to apply. Delayed anaphylactic reaction has been reported. So you should not, you should ask the patient, are you allergic to milk proteins, breast milk or any milk? Are you allergic to milk protein? If they are, please do not apply this. This is contraindicated in those patients. So go for varnish only. Multiple time patient has to come, that's all. But you get very rarely, very few patients with this problem there. The last step is follow-up. Regular follow-up. The fourth step and the most important step is regular follow-up by the patient there. You have to, I just want to show you a case where a patient has come to us. We educated the parents, educated the patients. Everything is done as a family treatment. We have done. We even rehabilitated the patient with the composites. Pulpectomy was done. Fluoride application, everything was done. And patient are happy and regular. Every year, 1 or 2 appointment just to see him. If required fluoride application, required anything will be done. And amazingly, when teeth started erupted, crowding got corrected. We got entire family with us. Entire family was with us. Luckily, without any caries. You can see still sealants are applied there and there is still remaining there. Now the 13-year-old no kid is happily walking into his adolescence life there. So we can actually prevent it at the right time. We intervene that, and follow up is the important thing. Whatever said and done, if you do not do follow up, wonder treatment is failure. So follow up is the most important step in preventive dentistry for a successful result that you want to come. So why preventive dentistry, guys? Preventive dentistry do not require any additional investments. You already have. Go to your clinic and see, oh my God, that conference I bought this varnish is still there. I'm not using. Let me see the date is. Oh, date is not. Let me start using it. Start using that Pit and Fisher sealant. The company gave you free. Is still lying down there, not using that. Please, no additional investment that you require. All what you need is the gloves, your suction, the mask, nothing else. And it is least aerosol producing. Least aerosol producing. No recurrent treatment you require. No recurrent treatment, no recurrent things that you require. All age group you can apply. Caries free joy you will get. Minimal aerosol generating process. So what beauty this preventive dentistry in clinical application is there. So we must apply it as early as possible. To conclude, dental caries is a disease. It is not a condition, it is a disease. And cavitation is a sign and symptom. You can do prevention by diet modification, home hygiene, which I did not cover, but I cover the professional care, which we can do apply daily basis. And that can change a lot. And to understand this, you have to have the knowledge about it. At the same time, your patient should understand it. Patient education, awareness in the community, in the society, in the individual family is important, and we should work for that. This is myself. You can contact me. Any queries that you have, I'm available in the social media. You can contact me, and let me thank you so much for the Association of Public Health Dentistry Indian chapter, Kerala chapter, for inviting me and giving me this opportunity. I hope I did justice for the time that you spent with me. Thank you so much, and have a good day. Let's hope you get back to practice as early as possible, and all the best for the rest of the conference. Thank you so much.